I thank Indian Arthroscopy Society for giving me this opportunity to present my technique of arthroscopic Bankart repair. So, in this presentation, not only am I going to show you what I do or how I do an arthroscopic Bankart repair, but I will also try and convince you that why I do it. To begin with, we all realize that arthroscopic surgery is an equipment intensive surgery, so you need a lot of tools and gadgets. You need the basic optic system, which includes the camera, the light source, the shaver system, the radio frequency ablator, and if possible, a fluid pump, besides many handheld instruments to do a good arthroscopic Bankart repair. You will need certain large size, preferably transparent plastic cannulas. You will need anchors, again, preferably non-metallic anchors, certain special sutures, high tensile sutures, and of course, plastic drapes to prevent soiling of the linen. I prefer to do arthroscopic Bankart repair in the lateral decubitus position. And this preference is because of the way I was trained and brought up. And over the last 25 years, I have found that this position allows me access all around the shoulder joint without any interference. It is important to tilt the patient posteriorly by about 30 degrees. This is to make the glenoid parallel to the floor. This slide is extremely important. The way you lay your equipment and anesthesia trolley is very, very crucial. You have to bear in mind that once you start the surgery, it will be very difficult and cumbersome to then shift the anesthetist or the anesthesia trolley. So make sure, as you see in the slide, that 180 degrees of the head end is free of any encumbrances, and that the anesthesia and the trolley is more towards the foot end of the patient. I use minimum 3 portals for doing a typical arthroscopic Bankart repair: the posterior universal portal, the antero-superior portal, and of course the antero-inferior portal. The scope will shift from the posterior portal into the antero-superior portal because the view is better, which I will show you in the next 2 slides. And all the instrumentation of the antero-inferior glenoid will be done through the antero-inferior portal where the large cannula lies. So here is the scope in the antero-posterior portal, and then it is shifted to the antero-superior portal throughout the surgery. So the reason why I do that is the slide lower left picture shows what the Bankart lesion and the glenoid looks like when you view from the posterior portal, and as against that, what the Bankart lesion and the glenoid neck looks like when you have the scope in the antero-superior portal. The vision of the anterior glenoid and the neck area is far superior when you look from the antero-superior portal. We must know the anatomy of all the 3 nerves which are around the shoulder joint: the suprascapular, the axillary, and the musculocutaneous nerves. So this is where they are. They are not too far. They are about a couple of centimeters away from your operating portals. Therefore, you must know the surface anatomy of these 3 nerves. In order to avoid damaging these nerves, we have this safe triangle, which is the area between the long head of the biceps and the subscapularis, as you see in this picture. The antero-superior portal is made just around the biceps tendon, and the antero-inferior portal is made as inferiorly as possible above the leading edge of the subscapularis. Now, the basic aim or concept of arthroscopic Bankart repair, and if you allow me, the aim of any surgical procedure is to restore or reconstruct the anatomy. If you correct the pathoanatomy, then success is inevitable. So what is the main pathoanatomy in recurrent anterior dislocation of shoulder? If I share my last 25 years experience of more than 2,000 cases of arthroscopic Bankart repair, I have a recurrence rate of 8%. And here are certain important arthroscopic findings which will help you understand the pathoanatomy and therefore enable you to rectify this pathologic anatomy. Number one observation is the direction of instability. I urge all of you that if you go home and look at any dislocated shoulder X-ray, they are usually antero-inferior and not just anterior. Have a look at this patient of recurrent anterior dislocation. We are looking from the posterior portal and my assistant is giving a little gentle traction inferiorly, and it very clearly depicts that the pathology or the direction of instability is truly antero-inferior and not just anterior. Here is example number 2. You can see the Bankart lesion anteriorly, but don't concentrate on that. Concentrate on the lower pole of the glenoid and look at the labrum. It is detached not only anteriorly, but even 6 o'clock and beyond, the labrum is detached. So this is basically implying that all these anterior dislocations are truly antero-inferior. And I won't be surprised if in a large number of patients, you will see that the labrum is affected, not only anteriorly, but inferiorly and posterior inferiorly, right up to 7 o'clock position. Either it is frayed or in some cases, as you see here, it is completely detached. So therefore, if you understand that the direction is antero-inferior, you will therefore want to correct the pathoanatomy and therefore tighten the capsule, not just the anterior, but all the way antero-inferiorly up to the 7 o'clock position. Only then you would have completely corrected the pathology. When you restore the hammock, as you see in this sketch, your aim is to restore the anatomy. Observation number 2, the extent of damage to the capsule labrum complex is not necessarily the same in every patient. It's variable. So we have designed a classification of injury to the capsule labrum complex. In type 1, you have an intact labrum, which is detached from the glenoid edge, which is a Bankart lesion, but the labrum is visible, is intact, and is nice and juicy, is seen in 34% of recurrent anterior dislocations. In type 2, again, you do have a detachment. However, the labrum is kind of disappeared or hibernated and difficult to identify. In type 3, again, you have a Bankart lesion. However, there is a lot of damage to the interstitial tissue or the mid substance of the capsule. And remember this type 3, the one with interstitial damage, have a high incidence of failure of arthroscopic Bankart repair and is seen in about 29% of cases. A bony Bankart is seen in less than 10%. Occasionally, the bone pieces are small and can be seen only on a high resolution CT scan. And type 5 is the only one where you need not have a detachment of the labrum from the glenoid, but just a loose, voluminous capsule, loose enough that the head can dislocate without actually tearing the capsule from the glenoid, and is seen in only 1%, particularly in patients with generalized ligament laxity. So here is type 1. You see that there is a detachment, but the labrum is visible, is nice and healthy, and this is type 1. This is type 2, where again, there is of course a Bankart lesion, which means there is a detachment, but the labrum is kind of dissolved or not easily identifiable. And this can also be labeled as an ALPSA lesion. But basically the labrum has fallen somewhere around the neck of the glenoid and got stuck in fibrous tissue. Type 3 is the one with a lot of interstitial damage to the capsule. So besides the Bankart lesion, there is a lot of mid substance damage to the IGHL. Type 4 is the bony Bankart lesion. And type 5 is a very loose, voluminous capsule, what is often called as the drive-through sign. And you can see here that there is hardly any thickened anterior band of IGHL that is visible. Observation number 3. The main pathology, I'm convinced after 25 years, is in the quality of the capsule or the collagen, which is essentially constitutional, perhaps genetic in nature. And the type 3 Bankart lesion, where there is a lot of interstitial damage to the capsule, has a statistically significant higher failure rate when you do an arthroscopic Bankart repair. We also compared the failure rate with generalized ligament laxity. And we found that in our Indian patients, 38.5% of the patients had some amount of laxity, which means 4 criteria or more positive out of the 9 criteria for GLL. We correlated generalized ligament laxity with recurrence rate and found that there was a statistical significant correlation of a higher recurrence rate after arthroscopic Bankart repair if you have a patient who has 4 or more criteria positive of the Brighton score. Also, those with 4 or more criteria positive of GLL are more likely to have either type 3 Bankart lesion or type 5 Bankart lesion. So all these statistically significant correlation between the Bankart type as well as ligament laxity tend to convince us that there is the basic problem of the quality of capsule or the collagen. Observation number 4, we tried to quantify the quality of capsule. So here are 4 different cases of recurrent anterior dislocation. And as you see here, the anterior band of IGHL is so variable in all the 4 cases. In some it is absent, in some it is thin, less than 4 mm, and the top left picture shows that it's a nice, robust, more than 8 mm thickness of anterior band of IGHL. Therefore, this difference in the thickness of anterior band has to have some significance. And we correlated this thickness of anterior band of IGHL with ligament laxity. And we found that there is a significant correlation. And in this graph, you can see that as the extent of generalized ligament laxity increases, the quality of capsule worsens. Now the technique 5 very important steps in executing a good, perfect arthroscopic Bankart repair. 1, you mobilize the capsule well. So if I do this operation for say 40 minutes, almost 20 minutes will be spent on mobilizing the capsule all around to the lower pole of the glenoid, and if required, even beyond that, because it is important to correct the inferior laxity as much as it is important to repair the anterior part of the Bankart lesion. So mobilize the capsule well, because we want to adequately tighten the inferior capsule. Extremely important to curette the edge of the glenoid. I'm not talking about the neck. We must abrade the neck with a rasp or a mechanical rasp or a burr, but I'm talking about curating the edge of the glenoid where your anchors are going to be inserted, and that is where the capsule is going to heal. So we need to create an environment of bleeding bone to enhance the possibility of healing of this capsule into bone. And therefore, it is critical to curette the anterior edge of the glenoid. Must use minimum 3 anchors, no less than 3, and if required, more than 3. There should be a 0 error in the knotting technique. So this is what I meant by curetting. There you can see a mechanical curette, which is used to curette the anterior edge. The articular cartilage is curetted, and a bleeding bony surface is desirable. And on the right hand side, you can see how the capsule is repaired into that bone that you have created by curating. Only then you can expect a good environment for healing of this soft tissue into bone, which is always a challenge. So here is a short video of the technique. This is a case of recurrent anterior dislocation of shoulder. So this will fall into type 1 Bankart lesion because the labrum is nice and easily visible and juicy and relatively easy to repair. So that is the anterosuperior portal just next to the biceps tendon. This cannula can be maneuvered behind the biceps or in front of the biceps, wherever you like, and you feel it is gives a better vision. That's the lower pole of the glenoid. The scope has been now inserted into the anterosuperior portal, measuring the anterior band of IGHL. This is somewhere between 4 to 8 millimeters, looks like. The very important step of mobilizing the capsule all the way up to the 6 o'clock position, then abrading the neck of the glenoid with a mechanical rasp, and then the curating of the cartilage edge on the edge of the glenoid. And that is where my anchors will be inserted. And therefore, I will ensure that the soft tissue is approximated into that raw bone created by my curating. I use a double loaded anchor, minimum 3, like I said. All the 4 sutures are taken in the posterior portal. A suture passer is used. You can use either a looped wire or a PDS suture, a monofilament, which is then brought out posteriorly. And then the suture, which is the one towards the capsule, is tied to the PDS and pulled through or railroad. You tie that suture, minimum 6 knots, with the 4th and the 6th knot being locked. And you can see how the capsule labrum complex is being attached into that raw glenoid edge. You repeat the same step with the second suture of the lowermost anchor past the PDS and use it to railroad the suture which is more towards the capsule, as you can see here. And again tie the knots, 6 knots, with the 4th and the 6th being locked. I would recommend that you do the same thing with 2 more anchors. And if the lesion is quite extensive, then you may need a 4th anchor also. So this is the repair. You can see a nice bumper being created. What is more important is how the capsule and labrum have been brought into that raw glenoid edge. And that is your best possibility of healing of this soft tissue into the glenoid bone. In patients with ligament laxity, I would restore the hammock by doing a tightening of the posterior inferior capsule. So what are the problems with the current technique? One is inadequate or improper tightening of the anteroinferior capsule, which is in our hands, how well we do it. But the second problem is beyond the surgeon, which is a genetically or a constitutionally poor capsule. And that is a subject of further research. When will I not do an arthroscopic Bankart repair? If there is significant glenoid bone loss. As you can see in this case, if the glenoid bone loss is 20% and above, then the chances of the arthroscopic Bankart repair failing are very high. How often do I see this kind of extensive glenoid bone loss in our country? In less than 10%. And therefore, you should be prepared that in about 10 or less cases out of 100, you may need a lethargy-like procedure. Remember that capsule is a biologically active membrane. It has proprioception, it has mechanoreceptors. So it is important to preserve the capsule as much as possible. Arthroscopic Bankart repair is not such a simple procedure. You need training, you need expertise, otherwise you can have all sorts of problems. And I recommend that do not use metal anchors as far as possible. Even with the bioabsorbable anchors, you can have tissue reaction, particularly in the generation 1 and generation 2 anchors, which are now not used much. But this is a patient where the second generation anchors were used, and you can see the osteolysis, which resolved with conservative treatment. In summary, arthroscopic Bankart repair with suture anchors for traumatic anterior dislocation is a successful technique, and the results are equal to open Bankart repair. So for my young colleagues, here is a simplified version, an animation of the technique, which will make it very easy for you to understand. So enjoy this less than 2-minute video. So I end my talk with this slide of a restored hammock. Success is more likely when you restore the anatomy. Once again, I thank the Indian Arthroscopy Society for this opportunity. Thank you.